Thank you, Dr. Ambach. So if you'll just pull up the slides. For those of you that are regulars watching some of our shows, welcome back. And for those of you who don't know us yet, I'm Dr. Chris Rogers. I'm a physical medicine and rehabilitation physician in San Diego, and completed a fellowship in non-surgical spine care and sports medicine long time ago, long before these two graduated from their training, and then got interested in regenerative medicine as an alternative to some of the more conventional treatments that I used for the first 15 years of my career. So for the last 15 years of my career, I'm using more cell-based therapy. So if you can advance to the next slide, Dr. Ambach. Thank you. So as I mentioned, we're fellowship trained physicians. We are very interested in academics. We've published quite a bit in this space in making our contribution to the field. We're also involved in clinical trials. Last year, we finished a phase 1/2A clinical trial on knee osteoarthritis using stem cell therapy. So that study has been completed and will be published soon. And then Dr. Ambach has also published extensively on the use of cell therapy for disc degeneration, one of the most common causes of disability in this country. Next slide. Dr. Diaz joined us more recently with extensive background also in physical medicine, rehabilitation, and sports medicine, fellowship trained in what we call interventional spine care and non-surgical spine care, and brings with her a wealth of knowledge and experience. So we're really happy to have Muriel join us. Next slide. So I met these guys a long time ago at medical conferences way before COVID, when we were traveling around the country 3 or 4 times a year, giving lectures, training doctors from around the world how to do these innovative therapies. I quickly identified Dr. Ambach as a rock star in the field, and was happy to be able to have her join our practice several years ago now. Next slide. And we, as I mentioned, we've contributed to the literature, both in terms of writing book chapters for our colleagues, which is always a good exercise, and we get out of it as much as we give into it. So just trying to move the whole field forward. There's still a number of physicians who haven't heard about cell-based therapies such as platelet-rich plasma or some of these others. So we like them to read these textbooks and get up to speed. So we've been able to contribute to that. Next slide. And so I created this space about 5.5 years now. Seems like just yesterday, but after being in practice for, I think at that point I was in practice maybe 20 years, decided to create this new practice here in Carlsbad. We have a lovely facility. We have a human being that will answer the phone when you call our office, which I like. We also have nice space to make you comfortable. And, you know, these are innovative therapies, and it requires that we as your physicians spend a good amount of time educating you about these therapies, as well as what other treatment options are available to you. So it's sort of a relaxed, no rush feeling in the clinic, so that we can answer all our patients' questions and make sure we're making good decisions together. And you see on the lower right there, our procedure room. Here's our lab where Dr. Diaz is sitting right now. And you can see that we have a variety of different techniques that we've helped develop. One thing you'll hear is that platelet-rich plasma, for example, one of the ortho-biologics that we use, can be made about 68 different ways. And we've learned the best way to do it. And we do that by doing quality control checks by using that cell counter on the lower right. So we not only do we assure that we're getting the adequate number of platelets, but that we can customize it in some cases, depending on what our patient's specific needs might be. So we're going to go over these things. We're going to, as Dr. Ambach mentioned, we're going to today focus on rotator cuff tendon injuries. We're going to talk about some of the non-surgical treatment options and the cell-based treatment options that we've helped innovate. We're going to have Dr. Ambach finish up by reviewing the scientific evidence, and then we'll take your questions and answers. So Dr. Diaz, you want to tell us a little bit about the rotator cuff tendon?
Sure. So before we begin, if you have any questions that you want to answer regarding the topic, whether regarding cell therapy or rotator cuff tears, There is a Q&A button at the bottom of your screen or a chat button. Either of the two works. Just start writing your questions. The presentation will be about 20-30 minutes long. And then after that, we will answer your questions in the order wherein we received them. All right, here's Dr. Diaz.
Hello, hi everyone. Thanks for joining us. So I'm going to go over a little bit about the anatomy, basic science of tendon injury. So when we say rotator cuff injury, we're talking about tendon injury. The tendon itself is the fibrous structure that connects the muscle to the bone. So the muscle doesn't connect directly to the bone. The tendon itself is a stronger structure that it's going to help transfer that tension from the muscle and activity and contraction of the muscle through the bone. The tendon itself consists mostly of collagen, and it can withstand a lot of tension, and that way it can protect the muscle from injury. Unfortunately, the tendon itself doesn't have a great blood supply, so it doesn't have a good capacity from healing itself. So that's why we hear so much about tendon injury. So the tendon injury can be either an acute tear from a trauma or a specific injury that you know, like, okay, something happened here, something new, or it can be a chronic injury. There's a lot of like overhead activities, athletes, and just regular jobs that require a lot of overhead activity. Overhead activity meaning anything that requires your shoulder to be above, your arm to be above shoulder level for prolonged periods of time, or repetitive use in that position. So when we say tendinopathy, that means injury to the tendon. And these are related, as we said before, due to overuse. And it can also be related to degeneration, which is age. You know, with age, everything can lose a little bit of its elasticity and loses some of that structure that we depend so much in terms of the tendon. So the tendon itself, when it's injured, it gets thick, it gets swollen, it loses that capacity to transmit that tension from the muscle to the bone. And at that point is that we start having issues. Next slide. So basically, this is the anatomy of the rotator cuff. This is a view of the posterior shoulder. So if we're looking at the patient from the back, and over here, you can see most of the rotator cuff muscles. The rotator cuff itself, its job is to stabilize the joint. So remember, the shoulder joint has a lot of mobility, which obviously we love, all the things that we can do with our shoulders, but in having that much mobility, we have to kind of compensate a little bit and lose a little bit of its stability. So here is where the rotator cuff comes in and helps to make that joint more stable. The rotator cuff are 4 different muscles, and if you can see there, the red circle is the one that it's they're like all the 4 muscles that consist. The rotator cuff consists of these 4 muscles. So these muscles are initially attached. Their origin is from the scapula, and then they attach to the humeral bone or the arm bone or shoulder bone. The supraspinatus is the one that is on the top of the shoulder scapular region. And that's usually the most injured tendon that we see. In this specific depiction, you see the red area, it's more the muscle itself. And when the blue region closer to the bone, that's the representation of the tendon. It's important to know that specifically the supraspinatus and the tendons that go the higher portion of the shoulder, they tend to be at risk of impingement. Many of you have heard that impingement. What that happens is that the tendon or the bursa, which is a small sac of fluid that helps decrease that friction in between the bone and the tendon. With certain activity, if you elevate your shoulder, that space between the bone of the collarbone or the acromion and the tendon gets smaller. And then that causes pain because it narrows that area over that tendon. We can also see here the other two muscles and tendons in the back of the shoulder, the infraspinatus and the teres minor. And then if we were to look from the front, that's when we can see the subscapularis. So I think in the next picture, we can see the subscapularis muscle. So over here, this is the front view of the right shoulder. And this, the big muscle and tendon in the front, that's the subscapularis. And the one here on top that shows the tear, that's the supraspinatus. So it's important to differentiate the two main disorders for the rotator cuff. One is tendinopathy, and then one is just an actual tear. So when we say tendinopathy, and this we can differentiate when we do ultrasound here in our office as a diagnostic ultrasound. The tendon itself has a lot of different characteristics when they start losing their kind of pliability, and that like it loosens up the tendon itself. So the tendons, when they start getting like overused or with age, they start getting like thick and brittle, and they lose that elasticity. That's the word that I was looking for. When there's an actual tear, those fibers are disconnected, and depending on how big or small the tear is, then we have to decide what type of treatment you're gonna get. So if you picture the tendon like a rope, I think that's the best description, because the rope itself is very strong, but it's very mobile as well. So it has that flexibility to move around. And then the rope itself, you can lose a little bit, it can start getting a little bit frayed, and you don't see certain, you don't notice it. But if that fraying is more extensive, then that can convert to an actual tear. And that's when we get into some trouble. So with the rotator cuff, a lot of patients have this condition. So we see it a lot here in our clinic. Basically, almost like half of the population above 50 years old are known to have rotator cuff disorders. And again, this can be a specific trauma, or it can be just changes with age. Their traditional management should start conservative treatment, as we usually recommend. And this could be, this is the conservative treatment that we're going to be recommending first. So first, there's some modalities like heat and cold. The heat is usually will be helpful to improve the blood supply to the region. And most patients see more benefit when it's more like a chronic, achy type of pain. Or we can use ice. Ice is usually helpful when there's more inflammation, or it's something more acute, more recent, and that helps to decrease that inflammatory process. It's important to know that the physical therapy and home exercise program is going to be an important part of the treatment that we do. Because with this, you're going to be strengthening all the muscle groups around it, the tendons, the ligaments, both to improve the pain that you're having at that moment, but also you want to prevent this from getting worse or coming back. In terms of medication, the two main medications are just anti-inflammatory medication. That's your regular over-the-counter Aleve, Motrin, Advil, ibuprofen. This is going to help decrease that inflammatory process. Or you can take some regular analgesics like Tylenol. Many patients like taking some medication before going to bed, because sometimes if you lie in that affected side, you're going to have difficulty falling asleep, or it wakes you up at night. So some patients see that it's useful to take that before going to bed, or when you know that you're going to be doing a lot of activity during the day and you already have issues with your rotator cuff. So the main, after the conservative treatment, the main injection that we have been all doing in the past, and we were trained in residency to do, were steroid injections. And we still know that the steroid has its place in certain patients. The good thing about steroids is that it's quick. So you're gonna see a quick immediate pain relief if you're having a lot of pain. But it does have a couple of cons as well. It's not gonna last a long time. The steroid itself is not doing anything to heal or prevent further injury to the tendon. On the contrary, it can be toxic to the tendon fibers. So we have to be very cautious when we're using it because it can actually cause further tissue injury in the shoulder. When you're using steroids, it's very important to use ultrasound. We can only put steroid in the joint and in the bursa, which are the spaces that we can safely put the steroid in. We should avoid putting any steroids in the tendon itself because it can be toxic to the tendon fibers. And then in more systemic issues, the steroids have been seen to worsen osteoporosis. Sometimes some patients, especially female patients, experience hormonal imbalances, and it also can decrease your immune response. Shockwave therapy is another option that we have in terms of treatment. The shockwave therapy uses sound waves to accelerate tissue healing.
Dr. Rogers, I'm sorry to interrupt. Dr. Rogers was showing the shockwave machine.
Oh, okay, I didn't see it. There it is. So this is a non-invasive treatment option, which has a lot of literature to back it up in terms of the treatment and the efficacy of this new therapy. So it's usually you will use like the machine that Dr. Rogers just showed you, that is this one in the picture, and it is going to be used to transmit those sound waves directly into the injured tendon, and that's going to promote healing from within. So it's going to be promoting more blood supply and increasing the collagen production on the long-term benefits.
We had a whole lecture and webinar on shockwave therapy, and if you are interested to know more about it, we actually have a recorded version of that in our YouTube channel.
There you go. And then we have to know that some patients are not going to be a candidate. There could be maybe a too large of a tear, or maybe a complete detachment of that tendon from the bone. And those are difficult to treat just with injections. So just know that if we feel that you're not a good candidate for this type of procedures, we'll let you know, and we'll refer you to our colleagues, surgeon orthopedic colleagues. Usually the patients that that have surgery, they will see some improvement in pain and improvement in range of motion, overhead activity. I'm talking specifically here shoulder surgery for rotator cuff repair. So basically what they do is, kind of like attach or improve the lower, decrease the space in between that tear, just basically sew it up or stitch it up and try to attach it again. The thing with this is that we have seen that many patients have short-lived benefits from surgeries, and some of them have the same type of benefits that they had with just regular physical therapy or pain medications. And there's a high rate of high failure rate of rotator cuff repairs. Anywhere from like 30% to 94% have been seen in literature. And this is because when they go in and kind of manipulate and the tendon itself, the tissue gets weaker. There's also some scar tissue formation in that region. So the tendon structure itself, the quality of the tendon is not going to be as good. And that's what we're trying to get to with the type of regenerative procedures that we do, is to actually improve the quality of the tendon itself. So these are some of the therapies that we offer, including PRP. and adipose-derived stem cells. So Dr. Rogers is going to go a little bit more over those specifically.
Great. Thank you, Dr. Diaz. So the name of our practice is the San Diego Ortho-biologics Medical Group, and patients will ask us, what is an ortho-biologic? And it just refers to biologic cell therapy that we use for orthopedic conditions. And there are many different kinds of orthobiologics. They're essentially cells or molecules that are derived from these cells. So the common cells you'll hear about are platelet cells, which are in your blood, or stem cells, which can be found in the fat tissue or in the bone marrow tissues. And then these cells will manufacture additional substances that are important for the healing process, such as growth factors and some of these other things you see listed here. So really it's, we call this translational medicine, right? So basic scientists have discovered how the body repairs itself after you break a bone or tear a tendon or cut your skin, something like this. And we're just using the knowledge gained from those scientific studies to create treatments for our patients who have these specific injuries. Next slide. And I tell my patients now, I'm basically a farmer now, where a farmer has seeds and plants those seeds in the soil and then fertilizes the seeds and waters it and adds some sunshine and some other nice things. And then your plant will grow. The same is true of this new field of regenerative medicine, but in this case, the cells, whether it's platelet cells or stem cells, they are the seeds, and then they can get placed in a scaffold. Sometimes it's combined with collagen or hyaluronic acid, or just placed in the tendon tissue itself, serves as the soil. And then the growth factors that are manufactured by those cells function as the fertilizer to stimulate the healing. That picture on the upper right, by the way, for those of you who aren't used to looking at knee cartilage under a microscope, that's what knee cartilage and knee bone tissue looks like. So we're trying to regenerate tissues in these cases. What is platelet-rich plasma, you may ask? So platelet-rich plasma is nothing more than a concentrated dose of platelet cells. These are small cells in your body that are the first responders to injury. So if you get a paper cut, the first cell on the scene will be that platelet cell, which will form a clot to prevent you from bleeding to death. So when we make platelet-rich plasma, we're taking those platelet cells and we're concentrating them, and we like them because they generate molecules that are called growth factors, many different kinds. Some of those growth factors will call stem cells to the area and encourage them to regenerate tissue. Other growth factors will increase the blood flow to the area, generate new blood vessels. Other growth factors actually function as anti-inflammatory drugs to decrease pain and decrease inflammation. And then, of course, you have stem cells natively in the tissue that will also be stimulated. I think one thing that's not widely known that we would like people to know is that if you go to one of the different thousands of clinics in the United States, you'll realize that PRP is not prepared the same way. So in that previous picture, you saw the person holding a test tube. Thank you. So in a test tube, that the patient's blood has been centrifuged, and the plasma, the water component, which has nutrients in it, is separated from the cells, the platelet cells in the middle, the red cells at the bottom. And then we can pull out various proportions of each to customize the PRP that we're trying to make, the platelet-rich plasma we're trying to make. But you can see these all look very different. Some of them look more like pineapple juice, some look like orange juice, and some frankly just look like blood. It doesn't look like they did anything with their centrifuge. And that's because in this case, different machines were used, different centrifuge systems were used to create the PRP. And what we're learning is that some of these naturally work better than others. Some have higher platelet counts, for example, which is necessary for certain types of tendon injuries, rotator cuff tendon injuries. So we are now, I think, on version 7 or 8 of our PRP based on our experience. And we actually manually process the cells and then we count the cells so that we know what we're delivering to the patient. The other orthobiologic that popped up there is stem cells. Some of you may think of stem cells as the cell that helps you regenerate tissue, and you are exactly right. They do this with many different very interesting mechanisms, but the other nice thing about a stem cell is it will generally make a copy of itself. So in this way, we have the theoretical potential to live forever. Nope, sorry, we don't live forever. But what can happen is the cells can make many copies of itself over a lifetime. Unfortunately, after a while, it runs out of the ability to keep doing that. And then eventually we run out of these cells. But it keeps us going for 100, 115 years, some of us. I think I just read that the oldest living person right now is 115. So lots of stem cells in that person, just regenerating tissue all the time, keeping them healthy and young. Next slide. The man who discovered the first of this specific type of stem cell, what we call the mesenchymal stem cell, or the MSC for short, was discovered by Dr. Arnold Kaplan. He discovered it and named it, and was able to show that if you put this little cell in a petri dish, it can turn into a variety of different kinds of cells: muscle cells, blood vessel cells, cartilage, nerve, bone, fat, some others. And so when Dr. Kaplan made this discovery, everyone got very excited back in 1991, because we thought, great, we can just regenerate, all these damaged tissues. You tear your muscle, we'll just put these cells in, they'll turn into muscle cells and you'll have new muscle. The reality is a little more complicated, it turns out. I don't know if that's on the next slide or not, but yeah. So this slide, this is what the MSC actually looks like. So you see those little pink guys in the upper left corner. They kind of hang on to your blood vessels. Those are microscopic blood vessels. You can't see them without a microscope. And those little MSC stem cells, we'll call them, wrap themselves around those blood vessels. They actually contribute to blood flow by constricting those vessels and relaxing. They actually connect to your nervous system, which is amazing. They have receptors on them. So they're part of your nervous system, which is crazy. But then if you get an injury, the nervous system not only gets excited, but then the injured tissue releases molecules that cause that sleeping MSC to become activated. And when it's activated, it produces all these different molecules that have a host of different types of function that we will just categorize as either molecules that heal tissues, molecules that decrease inflammation, or molecules that fight infection. So you can see very valuable cell with many different superpowers. We get these cells from any tissue in your body, but most of my patients don't want me to collect muscle tissue or kidney tissue. They're more than happy to let me collect fat tissue or bone marrow tissue. We don't really see these MSC stem cells in the blood. So when we make platelet-rich plasma, in the middle there, we're mostly going after the platelets. But if we have, say, a larger tear, a more difficult injury, maybe an injury that's been there for a longer period of time, you're going to need a little more firepower than what those little 10 or so billion platelets can offer. And so we can get 1 or 2 million of these MSC stem cells out of the adipose tissue. We can get about 50,000 of them out of the bone marrow. And then understand that these particular orthobiologics, as we would call them, don't just have stem cells in them, but they also have a variety of other cells and molecules that are also have also been shown to be helpful for healing tendon and arthritis and a host of other things. We always add this little caution. We realize that there are hundreds of what we'll just politely call bogus stem cell clinics that are usually offered by physicians who maybe either don't understand the science very well or know what they're doing, or just being a little bit dishonest. And they're selling products that are from a donor, in this case, amniotic tissue or umbilical cord blood. And while there are studies on these particular types of stem cells from umbilical cord blood or amniotic tissue, donor tissue, the FDA does not permit its use right now because it's not FDA approved, because we haven't proven it to be safe or effective. And so at this point in time, these types of treatments are not available on the marketplace. You can't use them. You can only use cells derived from your own bone marrow, your own fat, or your own blood. You cannot get a donor tissue. So the only way you would get it is if you were involved in a clinical trial. So, and in that case, the treatment should be free. So you should never pay for these until they are finally FDA approved. Next slide. Okay, Dr. Ambach, you want to tell us a little bit about what research has taught us?
Yeah, we're in the home stretch here. I promise we're almost done. We tried to keep our presentation less than 30 minutes. But we get so excited and passionate and we just keep talking sometimes. So Dr. Rogers will remind me if I'm taking too long. So there are a lot of studies on cell therapies for orthopedic conditions. tendon injuries is actually one of those orthopedic conditions that we have really good success with, along with joint osteoarthritis. So these are the ones that we really like treating with the cell therapies because patients do really well. As with any orthopedic condition, there's always a variety of mixed studies with regards to the efficacy of the cell therapies. This is one of those, no, this is not the recently published one. This is a 2013 published study on the use of PRP for rotator cuff. It is a high quality study wherein they randomize patients into getting a PRP for one group, and then the other group had a treatment that's called dry needling. So for those of you who don't know what dry needling is, you use a needle to actually stimulate and irritate the tissue so that the tissue will start to bleed, attract growth factors into the area, and stimulate healing into the region. With this study, and it actually has mixed results, but majority of the patients do well with dry needling, depending on the condition. So with this study, they want to directly compare PRP versus dry needling. And the study showed that the PRP group actually showed more significant reduction in pain, 72% versus 53% for dry needling, and also in their functional status. Their disability actually lessened more with the PRP group. There was no adverse effects with the PRP treatment. This is the one that was recently published, 2021. And it's also a level 1 evidence, high quality study comparing PRP with cortisone or steroids. So the participants were randomly assigned to either receive a PRP or a steroid. 32 patients had a partial supraspinatus tear, and they followed them up for 6 months. They have shown significant improvement in pain and function in the group that received the PRP treatment. There was no significant change. And when I say significant, I'm talking about statistically significant improvements in the steroid groups. And at 6 months, the average pain level with the PRP group was 14.5 on a 0 to 100 scale versus the steroid group, which had a 37.5 pain rating. Also, no adverse effects. If you look at the picture on the bottom here, the blue arrow is showing the dark area where there's a rotator cuff tear, and the right picture is showing the injection itself of the PRP into the diseased tendon. This is a study using PRP for those patients who had tried everything else for their rotator cuff tendon, but is just very resistant to treatment. 50 patients who failed all conservative treatments, they receive one PRP injection, and after 12 months, a year, the pain score and the functional scores of these patients who received the treatment actually significantly improved. 86% of the patients improved significantly. They slept better. Those who were practicing sports, 84% of them were able to return to their sports. Also, no complications with the PRP treatment. This is a study which we call a meta-analysis or a systematic review, wherein they collect, based on certain criteria, high-quality studies. In this case, they collected 16 high-quality studies, a total of 700 patients in all these studies, and all these patients had various kinds of tendon injuries. They compared the use of PRP versus traditional treatments like cortisone or control agents like local anesthesia and saline, which is your sterile water. Patients were followed for 2 years, and they have their conclusion from their meta-analysis showed that the PRP procedure or treatment was actually more effective than all of these control injections that was shown in the other studies: saline, anesthesia, cortisone, in various kinds of tendon injuries. Switching to cell therapy, this was a study that was published by one of our colleagues, Dr. Centeno, who used bone marrow-derived cell therapy for shoulder joint arthritis, glenohumeral joint arthritis, in addition to rotator cuff tear. 102 patients who failed therapy, and they were able to show significant reduction in the disability in these patients. Also, pain relief is starting as early as 1 month after treatment, which was sustained up to 2 years. Another cell therapy, this time coming from processed adipose tissue. They used processed adipose tissue for these tears, and they actually counted the cells, and they have shown that the group that had a high dose of cells had up to 90% reduction of the defect, not only on the MRI, but also on the arthroscopy. And if you look at the pictures in the bottom here, the yellow arrow is pointing to that white signal, which is the tear, the supraspinatus. And then after 6 months, you can see almost complete resolution of the tear and the defect there. Patients' pain was reduced up to about 50 to 70%. Patients had improved clinical outcomes. And so very good study showing use of adipose tissue cell. These are the next pictures will be patients that we have seen in the clinic. This is a patient that had a supraspinatus tear. You can see the red arrow pointing to that black signal, which is a 0.5 centimeter thickness of a tear. We call that hypoechoic signal. When the fibers are disrupted, it will show as black in the ultrasound signal. And after 4 months, with just 1 PRP injection, you can see a growth of the fibers towards that defect and resolution of the tear. Another patient of ours, professional golf player with a huge supraspinatus tear. Actually, we recommended for him, Dr. Rogers recommended for him to see a surgeon, but then he had a tournament that he wanted to play, and he wanted to explore non-surgical treatment options. So he was treated with adipose-derived cell therapy. And you can see the red arrow on the left pointing to that large defect. You can see the needle right next to the red arrow with a white fluffy stuff at the tip of it. That's the adipose tissue, the fat tissue with the stem cells. And then after 1 year, you can actually see almost a complete resolution of the tear, normal looking tendon. And he went on to play and won the tournament 8 weeks after the procedure. So pretty
against medical advice.
Against medical advice. This is actually this one is from a study that was published. Achilles tendon, that's the big tendon that in your heel connects your calf muscles to your heel. Again, red arrow pointing to that large defect there. The black area is the tendon tear. Patients had pain for 1 year. They treated the patients with a combination of PRP and fat-derived cells. The tendon tear resolved. Patients were pain-free. This is a patient of ours. Patellar tendon is that tendon that connects your kneecap to your shin bone. Again, big tear, partial tear, but this is pretty good size here on the left side. And on the right, 3 months after the injection with fat-derived cells and tissue, you can see resolution of the tear on the right side of your screen here. This was a patient of ours who likes to play tennis and pickleball. Also a big tear in her outside of her elbow. And after 3 months of using fat-derived cells, nice picture here showing growth of fibers towards that injury. And that's it. That ends our lecture. So I'm going to stop my share here and we will go on to...
I'll grab some of these questions here if you don't mind.
Yeah.
So some great questions. Just keep them coming in, guys, and we'll do our best to answer them for you. I'd like to take the first one. It's the most common question I've been asked for the last 14 years. Why does insurance not pay for these therapies yet? And I'm not an insurance company, and I still don't really understand the thinking, although I'm coming to understand it a little bit better. You know, the rationale from our perspective, right, as a doctor or as a patient, say, well, these are non-surgical. They're going to have lower costs. They're going to have lower risk. You're telling us that you're getting good results. You're telling us that these cell-based therapies are safe, which they are. Why would insurance pay for that? And the story I'm told is there are massive amounts of data that still have yet to be completed, right? So we've done the animal study, we've done the mouse studies, we show, we understand how tendons heal. We've done the human studies, Dr. Ambach just reviewed all those. What next needs to happen, large placebo-controlled randomized clinical trials need to be done. And then finally, the next step is you have to demonstrate cost effectiveness. So you have to show that treating patients with these treatments actually saves the insurance companies money. Insurance companies are not going to want to invest in these technologies, no matter, even though I can tell you people who work for the insurance companies have been our patients. But that aside, I think at the policy level, a lot of things have to change. We're getting there. We're getting there. There are a few insurance companies who now do pay for these treatments. There are a few companies that are self-indemnify their employees, so they pay for their employee healthcare costs, and they are absolutely on board because they realize the value. So they're starting to charge, but hopefully before I retire, insurance will pay for all these things. But right now, originally it was funded by all the athletes, right? All the professional athletes who wanted to keep playing, they paid for this. Next, we realized, well, it worked for athletes. The rest of us, the weekend warriors, we want to get treated. So now we're paying for these therapies, and hopefully insurance will eventually reimburse for these various services.
Yeah, I hope so. Next question, what degree of tear does PRP not work? There's a short answer to this and there's a long answer to this. Typically mild to moderate tears, maybe less than 50% of the tendon thickness, do well with PRP therapy. The more advanced tears, we tend to favor the cell-based therapy, either from a fat tissue-derived treatment or a bone marrow-derived treatment. Having said that, we look at the patient in general, right? So if a patient has, like this next question, Ehlers-Danlos, hypermobility, or any condition in their body that we know will affect the outcome of the treatment, we are, we're very conservative with treating. And I know we've given you all the conservative treatments and all the cell therapy treatments. I wanted to clear out that when we do see patients, we always try to do conservative standard treatments first, especially if they're seeing us for the first time, they haven't tried anything else, because we're giving your body a chance to heal. Some of these tendons heal with a good rehab physical therapy program, good nutrition, taking care of yourself, and all those good things. But majority of the patients, unfortunately, that we see in the clinic have tried everything else, and by the time that we see them, they're candidates for some alternative therapies. But yeah, so the answer to your question is, again, it just depends on the condition. We do find that small tears do respond really well to PRP, larger tears to cell-based therapy.
The rest of the answer, this is a very important question. When does it not work? Depends on how you define work, right? So for some people, it's just they want pain relief. For other people, they need to return to professional, sports. So we can decrease inflammation with a cortisone shot, right? But it's only going to get you 3 weeks of relief. You only get, you can get relief by taking a pain pill. It's only going to give you a couple hours relief. The question is, what percentage of patients will respond? How much of a response will you get? How robust will the healing be? And how long will that effect last? Ideally, we all want quick relief and we want it to last forever. The reality is more complicated. So for example, we have patients with full thickness tears. So this is the worst thing you can imagine, right? Full tears, completely torn. But we have patients who we've simply treated with platelet-rich plasma, where for years now they get relief because the inflammation is decreased, the nerves are not irritated, the tendon hasn't fully regenerated, but it doesn't bother them because they're not, doing anything too physical. Although I can tell you, I have a lot of golfers and swimmers and people that do use their shoulder still with full thickness tear. So as Dr. Ambach alluded to, it's a very complicated answer. It really needs to be answered on a case-by-case basis.
Yeah, also I was showing you all the nice pictures that we have. Not everybody will get these nice pictures, but even then they're feeling great and they're doing all the things that they want to do and they're playing their sports. So then don't get too hung up in how your pictures look like. They don't always correlate with your symptoms, and you actually see the clinical improvement earlier. In some occasions than the actual improvement in the ultrasound or the MRI. All right, next question. How do you manage frozen shoulder post-PRP? Or management of frozen shoulder post-PRP. The management of patients post-PRP is the same whether you have frozen shoulder or whether you have rotator cuff injuries. Frozen shoulder is a little unique because when we inject your tendons, you're gonna have more pain than your normal pain during the first few days. And some patients have a tendency to guard and not move their shoulder during those first few days. And obviously that will make your adhesive capsulitis or your frozen shoulder worse. So we really try to encourage patients to do their range of motion, their stretching exercises, more so if you have got frozen shoulder after the PRP treatment. Also, we can change the PRP composition such that it's not too irritating, it's more anti-inflammatory, and that can help with the frozen shoulder as well.
Dr. Diaz, you want to tell them what frozen shoulder is?
I'm sorry?
Explain. I don't think we explained what frozen shoulder actually is.
So yeah, so frozen shoulder, basically, the patient will see it as a decreased range of motion of your shoulder. There's inflammation of the capsule that covers the shoulder joint, and it can create restricted range of motion. So sometimes it can be painless, but you lose range of motion of the shoulder, which is very limiting in terms of function. So there are different things that can cause frozen shoulder, and there are other, like certain populations that are higher risk to developing frozen shoulder, like patients with diabetes. So it's important that the rehab part in frozen shoulder is very important to work with a physical therapist that will work at the same time with increasing, progressively increasing the range of motion of that shoulder, and to prevent it from getting worse.
Speaking of rehab, there's two questions here with regards to how to rehab themselves after an injection. So the first week after a procedure, you're going to be taking it easy. You're moving, you're up and about, but you're just not doing any strengthening exercises or nothing that's strenuous. But we encourage movement and range of motion. Second week after the injection, that's when you're going to be seeing your physical therapy, and they will start incorporating some light, weights and light strengthening exercises, and then you progress as tolerated. Usually return to sports don't happen until 3-4 months after injection, or even longer, depends on your sport and the severity of your tear. So it's really a work that you need to do. I always tell my patients the follow through is as important as the injection that I'm doing. So you have to do your part in helping improve the success of the treatment, and by doing your physical therapy and your rehab.
And we understand that physical therapy is uncomfortable when you have an injury, but when physical therapy is done properly, it should not hurt too bad. And there's always a workaround, right? You know, so if you can't lift 20 pounds overhead, you can maybe, lift 1 pound, or if you can't lift 1 pound, there's maybe some range of motion exercises you can do, or if you can't do that, you can at least work on your posture. There's always some level at which we plug you in. So I say, well, you're advanced, you're at the collegiate level, but this other person might be at 2nd grade. So we plug you into the appropriate level for where you're at. And having personally rehabbed many of my own injuries, I understand that there are phases, and you just want to be at the appropriate phase so that you don't re-injure yourself, because that's a real issue for some people. I'm going to take some of these questions here. This is an interesting one. How long do we think that the stem cells stay within the injection site? This is an area that's still under a lot of investigation. We do have some data in animals where stem cells from fat, for example, and there are different types of stem cells, we told you, but specifically stem cells taken from the fat, if they are injected into a joint, they basically stay in the joint. There's a cap around every joint. There's this capsule that Dr. Diaz was talking about. Think of a leather pouch that holds the fluid in the joint, right? The fluid's going to lubricate the cartilage. The capsule holds the fluid in the joint. So those cells basically stay within the stay within the joint, and they could be in there anywhere from 3 to 6 months. Platelets probably only stay in there for about 7 to 14 days. So quite a difference there. But the rest of the story is, while those cells are living inside that joint space, they are secreting molecules that frankly can leak out of the joint. And there have been studies that show that there are different ways of measuring inflammation, for example, in your body. So we can draw your blood, we can measure certain molecules, and we say, wow, your body's inflamed. You have a lot of these inflammatory molecules. You then inject stem cells into a patient's knee joint and look at the blood a few weeks later. You'll see a decrease in these molecules. So clearly those cells, even though they're still inside the joint, they're releasing molecules that are having effect on systemic inflammation. We don't know how long that effect lasts. It probably just lasts 3 to 6 months, that systemic inflammation effect. But the point being that these cells can have far-reaching effects. It gets even more complicated than that, because in the case of, say, knee osteoarthritis, or maybe if we're talking about the shoulder, we'll talk about shoulder osteoarthritis. Imagine that shoulder is inflamed, irritated by your immune system cells, right? Those immune system cells, what do? They're trying to eat up bacteria and viruses and all the bad guys. They're also trying to eat up all the damaged tissue, so the damaged cartilage, the damaged tendon. They're trying to clean and make room for new tissue to grow. But they also eat your stem cells. So, but those mean, nasty white blood cells, when they eat your stem cells, they become very nice. And when they become nice, what I mean by that is they start secreting molecules that stimulate new tissue growth. So we turn a mean nasty, it's called an M1 phenotype, you don't need to know this, macrophage, into an M2 regenerative macrophage. So we can change the genetic coding of the immune system after these white cells, immune cells, eat the stem cells. So what you're hearing me say is a very complicated answer.
It is. Everything about stem cell therapy is complicated.
Mhm.
Dr. Diaz, can you tell us about what Ehlers-Danlos is, and how do patients with this condition benefit from these kinds of therapies?
Yeah, so Ehlers-Danlos is a condition of the connective disease condition of the connective tissue in the body. So it has increased elasticity and hypermobility of the joints. So it goes together with increased laxity of the ligaments, of tendons. So it depends on how long has it been going on. This is a systemic issue. So a lot of different body parts are going to be affected by the Ehlers-Danlos. But specifically, if it's affecting more one joint that is kind of dislocating or is causing more pain, we can kind of pinpoint and address the ligaments around the shoulder. In this case, that we're talking about the shoulder joint, to try to tighten up those ligaments around that shoulder. So it's something that it could be helpful in terms of the PRP, trying to kind of cause some tightening of that ligament. Sometimes prolotherapy might be helpful as well for this type of conditions. But if it's something that might require several sessions and several treatments, because it's more of a chronic condition that it's within the systemic, that is more systemic than just an injury.
All right, we've only got 5 minutes. We've got 3 questions. Dr. Rogers, what do you think about data from umbilical or amniotic cell therapies? Is it promising in the future?
It's promising. We need more of it. So if you look at the stem cell research that's going on, all these clinical trials around the world, the stem cell, I think the thing that's important for everybody to understand, the specific cell that we're talking about, the MSC, the mesenchymal stem cell, which I showed that lives on little tiny blood vessels, lives on all your blood vessels, right? So that means that any tissue could potentially have these cells in them. So, but the ones that are most commonly studied are, as we said, cells from the fat tissue, cells from the bone marrow, or cells from umbilical cord blood, which of course would be donor tissue. So there have been very few studies. Most of the studies have been on bone marrow. The bone marrow stem cell source was the first to be studied. So there are most of the orthopedic literatures regarding that cell. Adipose stem cell research has caught up. So there's a number of studies. And to the last question that Dr. Ambach is going to address, that was a stem cell study. That's where you're actually growing these cells in culture. It's not what we do in the clinic. It's what's done in research. But the umbilical cord cell has been shown, again, to be very similar. So if you look at it under a microscope, if you look at the genetic coding of these bone marrow cells, these adipose stem cells, and the umbilical cord stem cells, they're basically cousins. They look, they're very similar to each other, but because they come from different tissues, they have slight variances to them. So for example, the umbilical cord cell seems to have pretty potent anti-inflammatory capability, and fat does as well, bone marrow less so. So they each kind of have their strengths and their weaknesses. But so far the literature is, I would say the issue is unresolved. I would say the jury is still out, which is the best cell. I don't think we've answered that question yet. But the point of the matter is I can't give you umbilical cord stem cells at this point as your physician. I can only give you your own adipose cells or your own bone marrow cells.
Yeah, and with regards to the last question, we had really good success in treating partial tendon injuries with even just PRP alone. And actually the exciting thing now is that we have a shockwave, or we call it BioWave, in our clinic. And there has been studies that potentially using the shockwave is a good synergistic treatment with these cell therapies, because it can potentially stimulate growth factors, stem cells to go to that area, increasing blood supply to the region, and just stimulate the healing process even more, and maybe facilitate better outcomes with the combination of cell therapy and shockwave therapy. So that's an exciting field that we are looking into, and having more studies published, I think, will help point us into the right direction.
I think as a last word here with the last 1 minute, I'll just tell everybody that, we treat folks who really have tried a lot of other things and are sort of stuck and need a little help moving along. But the vast majority of the people out there in the world don't need us. The vast majority of the people in the world need to do what you need to do today, which is go outside, get some fresh air, go for a walk, do a little exercise, whatever you love to do, because that grows tissue, that grows stem cells. That's how we function. When you work out in the gym, platelets and stem cells are going to your muscles and regenerating those tissues naturally. So it's free cell therapy.
Great advice, and what a great way to end the lecture. Thank you everyone for joining us. For those who have missed a portion of the presentation, we're going to put a copy of it in our YouTube channel, where you can find all other seminars that we have done in the past. Watch out for our subsequent seminars. We try to have something educational once a month. So watch out for our email and our posts in our Facebook. Thank you so much for joining us. Thank you, Dr. Diaz, Dr. Rogers.
Thank you.
Okay.
All right, have a great day, everyone.
Yeah, bye-bye.